Hi, this is Bassett McHale,
Christina Wilson.
and we're going to be discussing the case today we saw in the emergency room a few weeks ago of a woman with shortness of breath and a history of breast cancer. So HPI, this woman is a 43-year-old woman with a history of metastatic breast cancer to the lungs on chemo who presented to the emergency department with the acute onset of 1 day of shortness of breath within a context of a cough for about 3 weeks. And she had also mentioned that she had recently come back from a vacation where she had taken a long car ride there. She was able to hike during the vacation, but now was completely unable to walk. So on exam, her vitals were notable for tachycardia to the 130s, blood pressure of 104 over 59, and she was diaphoretic, she had cool extremities and faint pulses, and she was quite tachypnic, but her lungs were clear to auscultation, a little bit of decreased breath sounds at the bases, but otherwise relatively unremarkable.
So when you see a patient that comes in like this to your ED with a history of cancer, tachycardia, hypotension, what sorts of things would be on your differential?
Couple different things. So obviously with a history of cancer and this recent travel, certainly have to think about a pulmonary embolism given her history of cancer. She had a cough, so definitely think about pneumonia or maybe evolving towards more of a sepsis picture. Also have to think about pericarditis or pericardial effusion causing tamponade as well. So in addition to obtaining basic labs and chemistries as well as a chest x-ray, because PE was on the differential, the team decided to obtain a CT-PE to evaluate for embolism. And while the patient was awaiting her CT-PE, we obtained a bedside cardiac ultrasound. So here we're looking at the peristernal long view of the heart. So you can see here is the LV, here's the LA with the mitral valve, up there's the aortic inflow tract, and then the right ventricle wall, and then surrounding the heart we can see a large circumferential. You can actually see a little bit of the heart moving and varying within the pericardial sac as well. So when we see a large pericardial effusion like this, we have to immediately ask, is there echocardiographic evidence of clinical tamponade? And so there's three major signs to look at, and one of the three is to look at collapse of any of the intracardiac chambers. So looking here at the right ventricular wall, we can see the RV wall collapsing here. And the picture you want to think about is a man jumping on a trampoline, which we can sort of see there. And this basically happens because the fluid in the pericardium increases the intrapericardial pressure, and then the moment that that pressure exceeds the right ventricular diastolic pressure, the wall will collapse. So that's a very specific finding, not as sensitive. You can sometimes see right atrial collapse. That was not seen in our patient, but this is just a still image from a different patient looking at that. And this is extremely sensitive sign and quite specific as well for tamponade. Next, we obtained a peristernal short axis view. Again, you can see the large circumferential pericardial effusion, and again, you can see the swinging of the heart within the sac, and you can corroborate this with the EKG findings of electrical Ultrasound, so that's not quite as sensitive a test. Next, we obtained the apical four-chamber view. So here, we're sort of trying to visualize the right side of the heart here. We can't quite see the right atrium, but you can sometimes see RA systolic collapse there. So one thing to sort of keep in mind is that sometimes we can be tricked into thinking that you require this large of a pericardial effusion to cause tamponade, but remember that the key metric actually is not the volume of pericardial fluid, but rather the rate of accumulation. So the pericardial tissue is not very compliant at baseline, and so if you rapidly accumulate even a small amount of fluid, you will have sufficient intrapericardial pressure to cause tamponade. If, on the other hand, you accumulate that fluid very slowly, the pericardial sac can actually accommodate more than a liter of fluid before the pericardial pressure rises sufficiently to cause clinical tamponade. So keep that in mind, that it doesn't take an effusion as big as the one that this patient had to actually cause tamponade. Next, that's one of the main findings, is the collapse of one of the cardiac chambers. The next major finding is increased variation in flow across the mitral and tricuspid valves. So to better understand that, we'll just review some basic physiology here. If you think about the cardiac cycle during the respiratory cycle, during inspiration, you inspire, you decrease the intrathoracic pressure, so it becomes quite negative. So you have increased venous return to the right side of the heart. And then when you expire, the opposite is true, and so you have decreased flow against the tricuspid valve. So there's normal variability there between inspiration and expiration. And for the mitral valve, that's going to be less than 15%, and for the tricuspid, it'll be less than 30. Again, that's just for a normal heart. Now, when you have tamponade, because of the impaired cardiac dynamics and the intraventricular dependence that is present during tamponade, that variability will actually increase significantly. So mitral valve flow will vary by over 25 to 30%, and on the right side, the tricuspid flow will vary by over 50%. So the way that that's calculated is to use an apical 4-chamber view, and then to use pulse wave Doppler gate to measure the flow across the valves. You can see the 4-chamber view here. We have the gate placed over the mitral valve, and this is just looking at the flows. So you can see the respiratory cycle varying here with inspiration, expiration, inspiration, expiration, and then we're measuring the peak velocity across the valve. So you can see the peak here is measured by the machine at 113, and then the lower velocity that we can see there is measured at 70. And so you just calculate the difference there, the percent variation. We find that here it's 38% change on the mitral side of the heart, which is consistent with increased variation, which is consistent with clinical tamponade. The third and final major echocardiographic finding of tamponade is to look at the IVC and to see that it is plethoric. So what that means is that it's dilated, generally more than 2 centimeters, and that it doesn't vary more than 50% with respiration. So typically when you inspire, the IVC will decrease in diameter as there's increased venous return to the heart. Here we don't see that. So the IVC is both dilated and does have very, very little respiratory variation. This is a very sensitive sign. It's over 90% sensitive for clinical tamponade, and so if the patient does not have a plethoric IVC, it's quite unlikely that they have tamponade. Because of the findings that we saw here, we also proceeded to look at the abdomen as well, and we noticed a couple of different things. So here, this is looking at the right upper quadrant. You can see the liver here and the kidney with Morrison's pouch, and we noticed right away that there's this dark anechoic triangular area here, which is consistent with the right side of pleural effusion, and we know that that's the case because we can see a positive spine sign. So you can see the spine behind the liver here. That should normally stop right when you get to the diaphragm, but we see the liver continuing through, and the reason that that happens is that normally if you have an aerated lung, air doesn't conduct ultrasound waves well, and so once you get to the diaphragm and there's air, you won't see the spine anymore. If you have a pleural effusion there and there's fluid, that conducts the ultrasound waves well, and so you'll actually be able to see through. So this is a positive spine sign consistent with a right-sided pleural effusion. In scanning the rest of the abdomen, we also noticed that this patient had a little bit of free fluid at the liver tips. You can see the triangular-shaped, very sharply demarcated anechoic area there right at the liver tip, consistent with free fluid, kind of underscoring the importance of when scanning through, it's important to visualize the liver tip in addition to looking at Morrison's pouch. So what happened to this patient? So a few minutes after the bedside cardiac ultrasound, she decompensated and her blood pressure decreased to the 80s systolic, and she had an emergent pericardial drain that was placed at the bedside just on the basis of the bedside cardiac ultrasound images we obtained. 700 cc's of bloody fluid were taken out of the pericardial sac, and as is often the case with patients in tamponade, she had an immediate improvement in her vital signs and felt much better. Heart rates came down and blood pressure became much better as well. So, in conclusion, take-home points are that there's 3 major findings for echocardiac evidence of tamponade. They are a plethoric IVC, right ventricular or right atrial collapse, and inflow variation through the mitral and tricuspid valves. And so, if pericardial effusion or tamponade is on your differential, you should always do a cardiac ultrasound because it can save a patient's life, as it did in this case. Thank you.